My name is Ben Saville. I'm a senior statistical scientist at Berry Consultants, and today I'm going to talk to you about handling delayed outcomes in adaptive clinical trials. Many trials have significant delays in the time between randomization and the time of the primary outcome assessment. For example, we may have a clinical trial in atrial fibrillation where the primary endpoint is freedom from atrial fibrillation episodes through 6 months. In cancer, we may have mortality at 12 months, or in heart failure, we may have the peak oxygen saturation at 6 months. In each of these examples, we don't have the primary outcome observed for a given patient until we have a specified amount of follow-up. Now, this is typically not an issue when you're working with a fixed or non-adaptive clinical trial design. Now, we don't want to have to pause enrollment and wait for the outcomes of all the patients to come in before we perform an interim analysis. The idea of an interim analysis is to let the trial keep going, keep accruing patients, and we want to take a snapshot with our current data and allow adaptive decisions to be made based on the available snapshot. Now, with this snapshot available at a given interim analysis, there may be randomized subjects who don't have observed data on the primary outcome. And this is a little bit challenging in the sense that our adaptive decisions, such as stopping for early futility or stopping for early success, they really need to account for the extent of the unobserved outcomes. We also want to make sure that these snapshots are going to make use of all available data to make more efficient decisions and to make the best use of our data. With adaptive trials that have delayed outcomes, the accrual rate plays an even bigger role than normal because the number of patients with unobserved outcomes at a given interim analysis are going to depend on the accrual rate. If you have fast accrual and longer delays with respect to the time from randomization to the time of the primary outcome assessment, then you're going to have more patients with unobserved outcomes at the interim analysis. For example, if you take the extreme case of enrolling all the patients in your trial on the very first day that the trial starts, and you have a 6-month endpoint, you're not going to have any snapshots available that would provide you useful data for adaptations. It's too late. On the other hand, if you have very slow accrual and shorter delays in the time from randomization to the time of the primary outcome assessment, then that's going to translate to less patients with unobserved outcomes at the interim and essentially more information by which you can perform adaptations. I'd like to separate Bayesian adaptations with delayed outcomes into kind of 2 broad categories. Number 1, adaptations in which you're primarily interested in Bayesian predictive probabilities, and I'll talk more about this, but these correspond oftentimes to adaptive sample sizes, so stopping accrual for futility or stopping accrual for success. There are also other adaptations by which you're mostly interested in inference on the Bayesian posterior distribution. These include adaptations such as adaptive randomizations. This includes being able to drop treatment arms. And it also includes enrichment, where you have pre-specified subgroups by which you're allowed to drop certain subgroups depending on the observed data that you're seeing. Bayesian predictive probabilities are particularly useful for adaptive decisions regarding futility. Now, I'm going to define futility as a trial being unlikely to achieve its objective. And by that I mean it's unlikely to show statistical significance at the final sample size. This is inherently a prediction problem. The Bayesian predictive probability can provide the probability of achieving a successful or statistically significant result at the final analysis, given the current interim data. And this is obtained by integrating the data likelihood over the posterior distribution and predicting the future outcome of the trial. And this is done by integrating over all future possible responses. There's a paper that I wrote back in 2014 on clinical trials that I recommend for further background on this. At a given interim analysis, a trial is going to have 3 different types of subjects. Number 1, you're going to have subjects with observed primary outcomes. 2, you'll have subjects who are randomized but are lacking the primary outcomes. This is because they haven't had sufficient follow-up yet. And 3, you have subjects who are not yet enrolled. Now, a Bayesian predictive probability is going to condition on subjects with complete data in number 1, and it's going to integrate over all future possible responses from patients with unobserved outcomes. So that's 2 and 3, both the patients who are currently randomized but lack the primary outcome data and patients who are yet to be accrued. If the predicted probability of success at the maximum sample size given our current interim data is very small, such as less than 5%, the trial may stop due to futility. Now, to take a closer look at what this second group of patients, there's actually 2 types. There's subjects with no data because they were recently randomized and they just haven't had sufficient follow-up yet, Or we have subjects with partial data, meaning we have some sort of post-randomization outcome data, but insufficient for the primary outcome. So we may have their status at 6 months when their primary endpoint is actually a 12-month endpoint. And what we can do is we can use Bayesian predictive probabilities to model the primary outcomes using earlier what I'm going to call auxiliary outcomes, which may be correlated with the primary outcome. Now, auxiliary outcomes are earlier outcomes that are potentially correlated with this primary endpoint. In the simple example I gave before, if we have a primary endpoint being a 12-month outcome and we have an observed status at 6 months, those two things are likely to be correlated. So for example, if you have a 12-month primary outcome, we may have the status of a patient at 6 months. So if they've been enrolled 6 or 7 months in the study, we may have their status at 6 months. And even though we don't have the 12-month status yet, we know something about their post-randomization status, and this may help us predict what's likely to happen with that patient. Now, these auxiliary outcomes can be used to model these eventual primary outcomes that will be obtained, but they don't have to be a valid endpoint from a regulatory perspective, and they don't even necessarily have to be the same endpoint. If your primary endpoint is a response, it could be an underlying biomarker that changes based on the treatment, and you have a response over time. And even more, an auxiliary outcome, it doesn't even have to contribute to the primary analysis. It only has to contribute to the adaptive decision. The idea here is we're going to harness all available information, both in the primary endpoint that's observed, as well as in the auxiliary outcomes that you observe, to make a more informed decision about what should be done at this particular interim analysis. What we do is we use longitudinal models to build auxiliary outcomes into the predictive distribution of the primary outcome, and this provides a more informative predictive probability of trial success. For a simple example with 2 treatments, A and B, suppose you have a 12-month response as the primary endpoint. You also have an auxiliary outcome, which is a 6-month response. Now, at a given snapshot, a given interim analysis, you're going to have some patients who have both the 6 and the 12-month observed outcomes. And what we're going to do is we're going to use those patients to learn about the correlation between the 6-month and the 12-month endpoint, between the auxiliary endpoint and the primary endpoint. And we use that model. In this case, it's a binary endpoint, so it's probably going to be a beta posterior distribution. But we're going to use that model to help make inference with respect to the patients who are missing the 12-month outcome but might have the 6-month endpoint observed. So of those who are missing the 12-month outcomes, there are really 3 types. You have patients who are known 6-month failures, you have patients who are known 6-month successes, and you have patients who are 6-month missing, meaning we haven't had sufficient follow-up of 6 months in order to obtain their 6-month status. And what this enables us to do is to build 3 different predictive probability distributions, the first 2 of which are based on this longitudinal model where we learn about the correlation between the 6-month and the 12-month. In this case, we see a 6-month favorable response. They're probably more likely to be a 12-month responder. And if we see a 6-month failure, they're more likely to be a 12-month failure. And so we use these predictive distributions to provide a better predictive probability. And you can see here, that's essentially three predictive distributions per treatment arm. So here I'm showing here 6 beta binomial predictive distributions. They're going to have different parameters in there, but they're based on the data that you're observing. Predictive probabilities are also useful in monitoring trials for efficacy. And when I talk about efficacy, we're going to talk about success. And this is a loaded term that could mean a lot of different things. A scientist may view success as you've successfully answered the research hypothesis. A sponsor may view success as finding convincing evidence that the treatment is effective. And so that's the definition I'm going to use at the moment because I think it applies more to the predictive probability of interest that we like to use for our interim decisions. At a given interim analysis, if the outcomes of accrued subjects, meaning the patients that are currently randomized in the study, if they are all observed, then we can simply evaluate the success of the trial, in other words, whether the treatment is effective, by using a simple p-value or a Bayesian posterior distribution. However, if some of the accrued subjects have insufficient follow-up, there is a risk that stopping the trial early for success, that the final data set that you observe once you follow up those patients, it could be that final data set has a different conclusion than your current interim snapshot. A strategy that I recommend to avoid this is working with predictive probabilities in the context of delayed outcomes. And what we do is, at a given snapshot, a given interim analysis, we calculate a Bayesian predictive probability of success with the current randomized patients. Now, many of those subjects are going to lack the primary outcome. The idea here is we have a very high predictive probability of success, meaning, say, greater than 0.95. The idea here is we would stop subject accrual for expected success. We then follow all randomized subjects until the primary outcomes are observed, so it could be a 12-month endpoint, and then we conduct the primary analysis. One very nice thing about this type of design is there's only one primary analysis, and it always occurs 12 months, or however long the period of follow-up is to obtain that primary endpoint. It always occurs in this context 12 months after the last patient is randomized. And so we always have a mature data set. Now, the predictive probabilities are only used in making decisions with respect to the appropriate sample size. If we stop accrual for expected success, we are making the conclusion that the sample size is sufficient to address the primary hypothesis and demonstrate benefit of the experimental treatment regimen. This is known as the Goldilocks design, where we use Bayesian predictive probabilities to find the sample size that's not too big, that's not too small, but the sample size that's just right. My colleague Christine Broglio wrote a paper on this in 2014 that provides further background on this. In addition to having adaptations based on Bayesian predictive probability distributions, there are some adaptations that might be more focused on Bayesian posterior distributions. And some examples would include Bayesian response adaptive randomization, which includes arm dropping, or enrichment, in which we have pre-specified subgroups and we modify the inclusion-exclusion criterion based on the observed data and the responding subgroups. And the Bayesian methodology here that we often use is called Bayesian multiple imputation. The idea here is actually very similar in how we build these predictive probabilities, but we are using these longitudinal models of the primary and auxiliary outcomes to impute the unobserved outcomes. And we do this imputation many times, for example, greater than 1,000. And what we do is we base the Bayesian posterior distribution using these imputed data sets. And these posterior distributions allow probabilistic statements to be made based on distributions that incorporate the auxiliary outcomes. The Bayesian posterior that's used in these adaptive decisions does not necessarily have to be the same Bayesian posterior distribution that might be used in the primary analysis. The idea here is that we're going to harness available information in both the observed primary endpoint and the auxiliary endpoints. In summary, I've explained how delayed outcomes can create complications within adaptive trials. Bayesian predictive probabilities are extremely useful for adaptive sample size selections. They allow for a very natural way of using the interim observed data and to account for the uncertainty in the future outcome data. I've also explained how subjects with partial data can contribute to the interim decisions via auxiliary outcomes. This leads to better informed Bayesian predictive probability calculations. It leads to better informed Bayesian posterior distributions, and ultimately leads to better and more efficient adaptive decisions. I hope this has been a useful video. I encourage you to watch the other videos on the NHLBI Innovative Clinical Trials resource, as well as on the Berry Consultants YouTube channel. Thank you.